You know, days have changed, and I look around the room, and I know I've taken care of many of you for 30 plus years, and it's a different day and age. And thank goodness with technology and science, we have medications that's turned HIV into a chronic manageable disease. Probably a disease I'd much rather have than diabetes or heart disease. It's easier to manage. There's just a lot to it. And I think the younger generation doesn't really realize how bad it was when most of you in this room are old enough to remember that a lot of people would have a hard time surviving from one year to the next. And we'd celebrate a birthday or a Christmas thinking that it may be the last. And due to technology and changes, we've come to refine our care. And what I'm finding is, and what others are finding, is that as people living with HIV are living longer, we're subject to additional health concerns that are not HIV itself. And what I think separates good from great, and for what we're having a separate division now at my clinic to deal with, is people that are living with HIV over the age of 50. When medical students go to school, we're always taught that little kids or pediatrics is not taking care of adults, only smaller adults that weigh less. Pediatrics require different type of a care. And it's the same thing as we get older, our metabolisms and things change. And living with HIV is what we're going to talk about in a few minutes, that in spite of doing well, we tend to have chronic inflammation more than somebody that's not HIV infected. And that inflammation causes us to get older quicker. And so what we need to do medically is be very vigilant and be very aggressive of treating little disorders early. Many primary care doctors will say, well, your sugar's a little bit high, eat a little bit less, and not really treat a borderline pre-diabetic. Or somebody that has high cholesterol where it's a little high and say, well, avoid the hot dogs and eat a little bit more healthier. In the HIV realm of primary care, we can't allow a little bit of anything. We need to be aggressive for all these comorbidities and treat them aggressively, because at the end of the day, that results in lower inflammation and it results in living longer and healthier without consequences of heart disease or other problems. So we're going to be stepping up, especially with our HIV living population, and treat a lot of these disorders very aggressively, and more important, have a lot of surveillance for them. So I'd like to take a little poll to see where we're at the beginning, to see how well the Be Well Medical Center is doing. I may be a little fearful of the results, but you know what? We need the feedback from you. So if you can get out your cell phones and text to 22333, and then in the message, put my name, Paul Benson, 401. I'll give you a minute to do that. Question number one is, what is your age? Punch in A if you're between 50 and 59, B if you're between 60 and 69, C if you're between 70 and 79, and D if you're over 80. While we're waiting and you're getting this done, I'll go out of order and tell you something else that we're doing. Part of the program that we're doing is we're going to be having something called group medical appointments, or GMAs. In the first GMA, we've had them in the past, being a patient-centered medical home. We're required to have some, and we've done them on diabetes. But what we're going to be doing group medical appointments on moving forward is those people living with HIV over the age of 50. And we're going to be having them every 3 months. There'll be groups of 10 people. You will need to meet with Kiana, our social worker, before you enter a group medical visit. At that time, she'll explain them to you. You'll need to sign off on confidentiality, that you're not going to give anybody else's information out from what you may have learned at these meetings. And each meeting, we're going to take one subject and get into depth with it. It may be on nutrition, it may be on heart disease, it may be on osteoporosis. And you will, let's say it's osteoporosis, everybody in that group of 10 is going to get a DEXA scan to see if they're osteoporotic or not. Then they're going to go to that group medical visit. They're going to have their report in front of them, and we're going to talk about osteoporosis. So we're going to do that about several different diseases. Again, we want to increase your awareness. We think we can educate you much better if we do it in groups where we can spend an hour with you rather than 10 or 15 minutes. And the end result should be better health. We're at 17. Okay, we got a couple people between 70 and 79. I'm ready to move on. Is there anybody else that needs any help with this, or we're ready to do the next question? Let's try the next question. How long have you been living with HIV? Choose A if it's less than 1 year. Choose B if it's between 1 and 5 years. Choose C if it's between 6 and 10 years. Choose D if it's between 11 and 20 years. And choose E if you've been living with HIV over 20 years. So this kind of fits my perception of those I know in the room that I've been taking care of. About half of you have been living with HIV over 20 years. So you've certainly seen the differences in living with HIV now between 1990 and 2000 when it was a different world. Between 11 and 20 years, 28%, about a quarter. Between 6 and 10 years, 10%. And diagnosed between 1 and 5 years ago, 22%. We don't have anybody in the room here that's been diagnosed less than a year ago. How many of the following medical conditions are you being treated for? You got to put a number on this one, not the disease, but the number. So high blood pressure, depression, low testosterone, cancer, prostate problems, liver disease, osteoporosis, high cholesterol, or any other chronic disease. We want the number of these chronic diseases that you have. If you have none, you press A. If you have 1, you press B. If you have 2, you press C. If you have 3, you press D. If you have 4 chronic diseases, you press E. And if you have 5 or more, you press F. So while we're waiting for the rest of the answers to come in, I think if we were all 20 or 25 years of age, we probably would all be answering A or 0. Whoever the lucky person is that's pushed A or 0 right now, congratulations to you. You have my kudos. The older you get, the more medical comorbidities you have. Whether you're HIV negative or you're HIV positive doesn't really make that much of a difference. And when you live with, as an adolescent, you live with those words, it could never happen to me, and you don't become good pill takers because you don't need to take pills. It seems to me from my experiences that as you get older, you treasure and appreciate life a whole lot more, that you become more compliant in taking your medications. And when it comes to living with HIV over the age of 50, it's extremely important that you take your medications and you be aggressive for all these minor medical ailments that you may have. So if we look here, we could see most people in this room, about half, have 2 chronic illnesses. Some people have 1, about a third. And then about 5% have 4 or 5 or more. And my estimate of looking at this is a little shy. I think there's more chronic diseases going around than maybe you're counting on this. But the point of the story is still all the same. You know, the older you get, the more diseases that you have that need to be medically cared for. All right, now, next question. Not counting your HIV medications, how many other medications are you taking? So just do a finger count. Don't include your HIV medicines. Count how many other drugs you're taking. You do not need to include vitamins or supplements. Okay? None, you push A, 1 or 2B, 3 or 4C, 5 or 6D, over 6 other medications, E. And remember to hit send after you punch your number in. Letter, thank you. So about half of you are at least taking 1 or 2 other medications. About 10% of you are taking over 6 medications. And we'll talk a little bit about it in a few minutes from now, but as you get older, your metabolism changes, everything goes through your liver and kidneys, and you know it could be an issue. One of the things that need to be observed and managed, whether you're HIV positive or negative, is polypharmacy. And the older you get, the more medications you seem to be on. The more hospitalizations you have, the more medications you seem to be on. And many times when people get out of the hospital, the doctors there are prescribing duplicates of things you're already on. Because in the world of medicine, one drug may have 2 or 3 different names, or made by 2 or 3 different pharmaceutical companies. And so a lot of times you go in the hospital, they write a drug that's on formulary there that you're not taking at home, and you go home and you wind up taking double dosing. And it's not good for you for a number of reasons, as I'm sure you could be aware of. Insurance companies, we may or may not like them, that's your choice. But one thing that they are now paying physicians handsomely for is something called transitional care visits. And a transitional care visit is something as simple as when you're discharged from the hospital, you have to see your primary care provider within 7 days of being discharged. They pay the physicians a lot of money to get our patients in that are discharged from the hospital to see them within 7 days. They're not idiots. They're not doing it because they want to give their money away. They're doing it because they know there are so many medication mistakes from all hospitals that they want the primary care doctor to sort out the medication list and make sure somebody is not being dosed with too much medications. And I could tell you, at least half of the time, as unbelievable as it may sound, people come out of the hospital with duplicate medications of stuff they're already taking just with a different name of it. And why the insurance companies are doing that? Because it prevents rehospitalizations from overdosing of medications. So, you know, the older we get, the more comorbidities we have, the more medications we tend to be on. What condition concerns you most as you get older? You can only pick one. If you're worried about one thing, which one is it? A, dementia, B, cancer, C, HIV, D, heart disease, E, lipodystrophy, or F, other. You can only choose one. What most concerns you about getting older? Okay, so dementia rates number 1, and there have been studies between those living with HIV and those not living with HIV, and the number 1 concern that people have is dementia. Second in line here was heart disease. I mean, that would be something I would think would be very common, that people worry about heart disease. That's tied with other, whatever that may be. And HIV is only 5%. So I'm speaking to a very educated group here because HIV itself, the virus, is the last thing you need to worry about. As long as you're adherent and you take your medication every day, you don't have to worry about HIV. We got your back covered on that one. What number HIV regimen are you taking? If this is the first regimen you were ever prescribed, then you would answer your first. If it's the second regimen you ever prescribed, you'd answer B. Third, C. Fourth, D. 5 or more regimens, you'd answer E. Interesting. So if I was talking to a group of people 20 to 30, I think we'd see that everybody would be on their first regimen. If you look here, 38%, so about 4 out of every 10, this is your 5th or more regimen. Boy, you've been through a lot. But you know what? It's great that you are able to appreciate and take advantage of the technological changes and advancements in medications. No longer is medication toxic like it was in the old days. Now it's simple, take 1 pill once a day. All right, I think maybe there's a couple more questions. Is your viral load currently undetected or detected? If you're undetected, choose A. If you have a viral load and you're not undetected, choose B. And if you don't know, choose C. And if you're a patient at the Be Well Medical Center and you choose C, Caleb and I are going to be in tears. Okay. So this is above national average. You know, 10 years ago, if we had 75% above undetected, we'd be doing very well. Nowadays, for most practices, you need to be about 90% to be saying that you're doing well. And Caleb, doesn't that look good? 100% undetected. That is really, really sweet. That means we're working well together as a team. This is the one Caleb and I might want to go out of the room for. Which of the following is true about your cholesterol? A, I don't know if it's an acceptable range or not. B, I'm on treatment and at goal. C, I'm on treatment and not at goal. D, it's good and I'm not on treatment for high cholesterol. Not bad. All right, so about a third of you are good on treatment and at goal. So 70% have normal cholesterols in the room. So that means 3 out of every 10 of you, we got our work cut out, that we got to get you at goal. Remember what we said? Living over the age of 50 with HIV, we got to be aggressive and get your numbers where it needs to be. So we're glad to see a majority are where you need to be, but we need to be doing a little bit better. Which of the following is true regarding your blood sugar? A, it's normal without any treatment. B, it's normal and I'm on medication for blood sugar. C, it's not normal and I'm on medication for it. Or D, I don't know what the hell my blood sugar is. All right, everybody's answered. So 75% normal blood sugars. 25% as a clinic, we got some work to do to make our population better at blood sugars. What is the status of your colon cancer screening? A, it's up to date. B, it has not been done. C, I don't know. Colon cancer screenings. All right, so 2/3 of you, it's up to date. 35% of you, it's not been done or you don't know. So again, I'm going to tell you our plan to get 100% on everything here at the end of the lecture. Regarding osteoporosis, A, I don't know if I have this condition or not. B, I have osteoporosis and I'm being treated. C, I never had a DEXA scan to find out. And D, I've had a DEXA scan and it was normal. no loss of bone density, no osteoporosis. So about half of you have never had a DEXA scan. This goes along with the standard of care for treating HIV and osteoporosis. Is doctors are really not looking at this, and we'll talk about it in a few minutes as well. It's not necessarily the right answer. We have a DEXA scanner in our office. We should be burning it up and using it because we got so many high-risk people, yet we're not ordering as much tests as we really should on you. It's recommended that if you're over the age of 50 living with HIV, you should have a DEXA scan to find out where you're at. Again, preventive medicine is the best medicine. We don't want to slip and fall in the middle of the night and break a hip because you have osteoporosis and it's been left untreated. Regarding if you're a man and you have a prostate-specific antigen, a PSA, if it's normal and it's been checked in the last 12 months, choose A. If it's abnormal and you're being managed for it, press B. And if you don't know what your PSA is, press C. PSA should be done yearly after the age of 50 or 40 if you're African American or have an immediate family history of prostate cancer. So again, it's about 50-50. 60% or so have been getting it checked. 45% either don't know it's been checked, we didn't give you that information, or it hasn't been checked. So again, we're going to raise the bar on that. And again, I'll tell you that plan afterwards. I average the following numbers of sleep each night. A, 8 or more hours. B, 7 hours. C, 6 hours. D, less than 6 hours. Sleep. So about 60-65% of the individuals in this room are getting 6 hours of sleep or less than 6 hours of sleep. Only 17%, less than 1 out of 5, are getting the recommended 8 hours sleep each night. And we're going to talk about sleep in a little while as well. I sleep well and I wake up refreshed. A, strongly agree. B, agree. C, neutral. D, disagree. E, strongly disagree. So about a third of us are not sleeping well at night. We don't wake up refreshed. I'd like to be in that 5% that does wake up feeling all refreshed in the morning. Okay. We have gone through a lot of evolution. We're not the same people we were a couple million years ago. We're not the same people we were 10 or 20 years ago. Our bodies are programmed evolutionary-wise for something called the stress response, either flee, fight, or flee. And back to our prehistoric ancestors, their threats, their stress was either to look for food to eat something or to run away so they're not food for some other animal or predator. And that's how we're designed. It's called our sympathetic nervous system. Yet the stress that we have today is not necessarily finding food. It might be stress from work or stress from family. And even though we're programmed to run away or fight or flight, we're not fighting or flighting. So it turns into free-floating anxiety or it turns into depression. And unless you really know how to manage it, it can have effects on your health. We don't look alike either. We've kind of changed. Our dresses changed. We're just not the same anymore. Things change. And you know what? We have to change with the times. It's important that we do that. It's important that we take advantage of new science and technology and advances that we have and not be stuck in the 1960s. Look at the telephone. We're probably all old enough in this room to remember the rotary dial telephone. If we were to talk to most 20 and 30-year-olds, they look at that and have no idea what that prehistoric device was. Because now everybody has cell phones, iPhones. And not only that's what's changed, but our sexual habits are changed. Sex is a very complicated subject, and it constantly changes. And now with all the social applications like Tinder or Grindr, people can order up sex into their rooms, the same as ordering an Uber or a pizza. And it's much different than it was many years ago. My mom and dad claimed that they were virgins before they met either. God bless them, rest in peace, both of them. I'm going to believe them and take them at their word at that. I'm not sure if that's the same in the year 2019 as far as the sexual habits. I'm not saying one's good, one's bad. I'm not saying that at all. I'm just saying it's different today than it was in the olden days. And if we don't appreciate the sexual habits of the younger generations coming out, and they don't appreciate the sexual habits of the older people that are available right now, there's a mismatch, and it's not good. I love this advertisement. This was an advertisement in a magazine called Life magazine. Does anybody remember Life magazine? The picture magazine? I see most hands go up. So this came out of Life magazine, and it talked about advertisement saying more doctors smoke Camels than any other cigarette. And it talked about that T-zone, the pleasurable zone on the tongue. And this was in the 1960s, 70s. At the top there, you can't really read it. It talks about the good old doctor getting calls in the middle of the night, a couple hits on his cigarette, wink, wink, and he's up early in the morning to get back to work saving lives again. You know, I remember, and you may as well, physicians would be smoking in the exam rooms. I mean, there's been a lot of changes back then. We look at this now, and it's ridiculous. And I hope 20 years from now, when people look at the treatments that we're doing for HIV today, they look at that as ridiculous as well, that we have stamped out this disease and it's not even there anymore. So, people are living longer with HIV. Everybody in this room is testament to that. And in 2015, 50% of those living with HIV were over the age of 50. In 2019, my guesstimate, it's probably around 60 to 70% of people living with HIV are over the age of 50. See, we're all doing better. And because we're doing better, we're living longer. And that's the whole reason why HIV care and primary care is different now than it was 10 years ago, because 10 years ago or 20 years ago, people, for the most part, were not living with HIV, were not living to get to be 60, 70, 80 years old anymore. Well, now that's common. And so we cannot treat, the medical profession cannot treat somebody living with HIV that's over the age of 50 as a normal person, like an uninfected HIV. We need special attention if you're living over the age of 50. We need special attention. And I'm not the only one going around and saying this, because in the HIV community now, in the World AIDS Conference, we're all addressing the different type of care that's needed for somebody living over the age of 50 that's living with HIV. So I'm the messenger here giving you this information. This is not me. This is not something I made up, something I discovered. Is it something that I believe in very strongly? Absolutely. That's why we're here tonight. Medicines have certainly changed. Many of you in the room here that said that you've been on your 5th or 6th regimen, remember the days when you were on 20 or 30 pills a day and had to wake up in the middle of the night to take your AZT. It's changed. We're now down to 1 pill once a day. And you know what? You're all going to have the option, or most of you are going to have the option by the end of this year, by this summer, to go on an injection once a month and get rid of pills altogether. I mean, that's where we're at, and it's going to be happening by end of this year, probably later in the summer. So we have made a lot of advances. And one of the things, we talked about the cell phone and the rotary phone, some of the things that you need to remember, you all grew up in the days, we were pioneers for sure, when medications were toxic and they make you sick. And sometimes you wouldn't want to take your medications because the side effects of the medications were worse than having the disease. And many people would run away, and a lot of you are nodding your heads. You know what I'm talking about because you lived through it. You really need to give up that notion. Like we talked about earlier, things have changed. The medications are no longer toxic. They work well and they're well tolerated. And you shouldn't be scared of change, and you should make your life easy and live with HIV, not let HIV live you. So one of the reasons that people living with HIV age more rapidly, it's all because of this nasty inflammation. Inflammation causes much damage in the body. And everybody has HIV, everybody has inflammation, whether you're HIV infected or not. However, numerous studies have shown when people are infected with HIV, they have a very high markers of inflammation in their body. There's about 20 different markers that we can look at for inflammation. They're done in research, they're not done clinically, except maybe for a few cardiac advanced lipid tests. But everybody that's HIV infected, not on treatment, has very, very high levels of inflammation. Once you go on successful treatment and become undetected, your level of inflammation floating around in your body drops perhaps 80%. But you never get the same amount of inflammation as somebody that's not HIV infected. All right, it never drops to that level. If you're living with HIV, you need to face it, you're living with more inflammation. That's just the way it is. But you know, HIV is not the only disease. Rheumatoid arthritis, high blood pressure, other ones cause increased immune activation or inflammation as well. But it's something that we have to deal with. And it's this inflammation that causes premature aging. It's this inflammation that causes people living with HIV to have heart attacks at an earlier age as compared to somebody that's not HIV infected. So really, treating HIV now, the challenging part is not treating the virus itself, it's treating the inflammation that goes along with it. And we're going to talk about some of that. If you look at HIV effects on long-term health, the orange bars represent those people that are HIV infected. The blue bars represent people that are not HIV infected. And they compare it to the general population, look at incidence. And you can see hypertension, the prevalence of hypertension if you're HIV positive is much higher than if you're HIV negative. Non-AIDS related cancer, much higher, almost double, as compared to non-AIDS related cancer in somebody that's not HIV infected. In fact, I was surprised to learn about 6 or 8 weeks ago, it used to be that liver disease was the #1 cause of death in people living with HIV. It is now non-AIDS related malignancies that HIV people get is the #1 cause of death if you're HIV infected. So what does that tell us? It doesn't mean we sit down and take it. What it means is that we as providers need to be very, very aggressive in all your cancer screens. Prostate cancer, colon cancer, breast cancer, cervical cancer, lung cancer. Every cancer occurs in a higher prevalence in those that are HIV infected as compared to those not. So great care involves being very vigilant at surveilling for cancers. Because most cancers are treatable, if not totally eradicated, if you pick up on them early enough. We looked at that screen earlier about colon cancer and PSA. 40% of you either didn't get screened or don't know what your results are. My mission tonight is to end that ignorance, and we're going to do a lot of vigilance to make sure that we're following you the way that we should and that you're educated to know what your numbers are. And if you don't know, then you need to ask us.
Doc,
Yes.
what's MI and PAD?
Okay, so MI is myocardial infarction, the rate of heart attacks. PAD is peripheral artery disease and cerebrovascular disease. You can see in all these comorbidities, the rate compared to the general population is higher in those living with HIV compared to those not.
In that study, though, you should be said, that's controlled for treatment as well. So all the people are matched up. So it's not like the group without HIV smoked less or something like that.
They 100% matched up. If they were, with the proportion, if they were smokers or whatever it was, they were all filtered out. So it was, you're measuring apples to apples. So one of the systems that inflammation affects is a neurological symptom. And as you get older, our mental function tends to decline. We sometimes have to reach to remember what words we're saying or where we left our keys, all sorts of things on that area. It's just a factor of getting older. That's just the way it is. And in HIV, it accelerates and happens at a quicker rate. Some of the things that you can do is exercise your mind and body, do crossword puzzles, Sudoku, read the newspaper, music in the house. I've talked to many neurologists that make the statement that if your home has music and sound in it, it's good for your mental function, less chance of dementia. Practice moderation in what you do, and good sleep hygiene. So these are like common sense things that you can do to prevent neurological decline. Dementia, which was the #1 rated concern in this group tonight that we went through, is dementia living with HIV is very different in 2019 compared to the 1980s. People that were living with HIV that had dementia in the 1980s, they literally lost their mind. They couldn't talk, they were zombie-like, they shuffled their feet. It was like having advanced Alzheimer's. And it's pretty sad when you see somebody that's 20 or 25 years of age have that. Dementia in 2019, thankfully, we don't see those issues that we saw in the 1980s. It's more of just getting older quicker, that rather than be totally demented, you're just inhibited and you're just not all with it. Your memory goes quicker, your balance goes quicker, things on that order, but it's not full-blown dementia that you can't function. So there's a lot of people running around nowadays that are HIV infected that have mild dementia. And there are tests for this. We, at our office, got a piece of equipment called a CogniView that, again, we're going to ask everybody over the age of 50 living with HIV and those under the age of 50 to get this test for cognition to see how well your memory is and how well your brain is functioning, and then we might be able to compare it year to year. And if we see a decline, then we really need to get busy with some of the factors that we can do to prevent further decline. So it's very, very important. One of the things that concerns me about dementia is that in Michigan and many other states in this country, medical marijuana is now legal. And we've signed hundreds of medical marijuana forms for people that are HIV infected to smoke marijuana or eat marijuana or whatever, however you want to use marijuana, rub it on your skin. You know, it's fine, I get it. However, things need to be used in moderation. And I am really, really concerned with the potency of marijuana that's available in 2019 compared to the 1970s, where it's like 20 or 25% more potent or more than that, and that people are getting toxicities due to marijuana because it stays in your body for a while. It's not like it goes away. So I get the recreational idea of it, and everybody likes to be happy, and I'm not against that at all. But what I'm saying is, especially if you're over the age of 50, and if you choose to use marijuana to make you feel better and have less anxiety and less depression, fine, go ahead and use it. But I beg you all, use it in moderation. I'm seeing many patients come in, they stink of marijuana when they come into the office. Have a little respect when you see us, to not come in stoned or not come in drunk. And we can have a more effective relationship that way if you come in somewhat sober, not have a joint in the parking lot before you come in and see us. But it sounds funny, but it happens more often than you would think that it happens. So if you are going to smoke or use marijuana, whatever form that you want, I beg you, for dementia and your neurological function, you need to do it in extreme moderation. Don't make it habitual that you're smoking every day or several times a day. Treasure it for a nice recreational, have fun type time. It should not be something that's used on a daily basis. If you choose that, that's your business. As a doctor, I'm just telling you what we recommend. Depression. The top bars here that are in blue list the general depression in the United States for non-HIV patients, and it rates anywhere from 6 to 9%. 6 to 9% of people living in the United States are depressed, have been diagnosed with depression. There are 4 studies here for HIV positive individuals, and the rates go anywhere from 14 to 20%. So that means about 1 out of every 5 people that are living with HIV have some form of depression. Some mild, some very severe. And sometimes we treat with antidepressants, sometimes we treat with mental health, but depression leads to many bad things. And everybody living with HIV should have the joy of life in them. They should not be walking around depressed. So we're going to be bringing that conversation up with all of you as well, and figuring out a medical action plan that we can deal with any amount of depression that you may be having to try and improve upon it. Scientists have discovered a revolutionary new treatment that makes you live longer. It enhances your memory. It makes you feel more creative. It keeps you slim and avoids food cravings. It protects you from cancer and dementia. It wards off colds and the flu. It lowers your risk of heart attacks. You will feel happier, less depressed, and less anxious. Are you interested? Huh? Y'all like that idea? Somebody gave a good guess, and I heard exercise come out. Exercise may fit the bill here, but it's not what I'm recommending. It's 8 hours of sleep each night. So I have just about finished a book that I highly recommend. It's called Why We Sleep. It's absolutely phenomenal. And it talks about all the different stages of sleep, why you need 8 hours of sleep and why you cannot cut down on 8 hours, how the body repairs itself, how your brain, the hypothalamus in your brain, takes the memories from the day and puts it into the cortex to help you remember what you need to know and throw out the garbage that you don't need to know. Sleep is very misunderstood. It's not studied that well. It's essential. Every living organism has to have a period of sleep. There is not one living organism that doesn't sleep. And sleep is so important for keeping healthy for so many reasons, not limited to, but especially for inflammation. Remember we talked about inflammation being a cause of premature aging? Well, sleep gives you a chance to get rid of all those toxins in your body. And yet we answered the questions here. Most of you are not sleeping 8 hours a night, and I think it was 40% of you are not waking up feeling refreshed. So sleep is something that is a good part of therapy. It may require a lot of discipline to be able to get 8 hours, but according to this book, you need 8 hours sleep. If you want to feel healthier and live longer, 8 hours of sleep. And again, the book is called Why We Sleep. I highly recommend it. Do you have a question?
Do naps count?
No, naps do not count. But very interesting, the book talked about the importance of naps, And they even talked about the Greek culture, how they close up all the stores and everything from 1 to 5, and people go take naps during that period of time. People have sex between 1 and 5. It's like we're biurnal individuals, and naps are important for you, but it still doesn't do the reparative effects as 8 hours of sleep is. But great question, yes. I'm not aware if getting over 8 hours sleep is detrimental or not. I didn't finish the book yet. Maybe it'll cover it towards the end. I'm about 3/4 through. Very, very important. And it's easy to do. For those of us that are older, some things for safe sleep: have a side light next to your bed, have a motion detector in the bathroom to turn the light switch on, remove obstacles and rugs going from your bed to your bathroom, and keep a phone nearby with an emergency speed dial. Most people that fall, slip, and boom in the middle of the night is when they get up to go to the bathroom. And as you get older at night, you sometimes may have to get up a couple times to go. And that is the highest incidence for hip fractures in the elderly is getting out of bed and going to the bathroom at night and slipping on something on the way to the bathroom. So it's an easy safety thing that you can do as you get older to prevent that from happening. Bones. It's a normal function that as you get older, you get thinning of the bones. And that's accelerated by HIV, perhaps by aging, or perhaps by some of the medications that you may be on that causes osteoporosis. If you look at this graph here, the blue is non-HIV patients, the yellow or orange is HIV patients, and the one on your left is on women, the one on your right is on men. This is the incidence of bone fractures according to age. And you can see in the HIV men, it's over double if you're HIV infected as compared to if you're HIV negative. And they did the same control studies that they did in the other one. They looked at like 2 million non-HIV infected individuals versus around 8,000 that were HIV positive. And you could see the difference in bone fractures. Huge. It's something we need to be preventive with you. And I think as a clinic, we could do better. And I'm pledging you as tonight, starting tomorrow, we are going to be doing better in screening for osteoporosis and treating it. DEXA scans are the only way you can tell if you have thinning of your bones or osteoporosis. If you have it, there's lots of treatments: testosterone therapy, weight-bearing exercise. And when I talk about weight-bearing exercise, it's not necessarily pumping iron, it's walking. Walking is a weight-bearing exercise. Using supplements, maybe calcium supplements. Biphosphonates is a medication we could prescribe. And of special concern is the transgender population. Because the transgender population, we've been chemically castrating them by putting them on medications to lower their testosterone for transgender women. And testosterone is important for bodybuilding and bones. So when we have these young transgender individuals that are 15, 20, 25 years old, we're medically castrating them by putting them on anti-testosterone agents and putting them to such a falsely lower level that they shouldn't be at for the name of them having a better phenotype or body. We're setting up these individuals when they turn 40, 50, or 60 to have major osteoporosis. So, I caution transgender individuals, yes, use your anti-testosterone medications, but don't take it to the nth degree to try and get to a 0 level like many want to reach, because they're going to have effects when they get older. And unfortunately, these effects are not going to be something that's reversible. Yes? It's a great therapy, yes. It's intravenous. It's something called reclass. We don't do it here. Usually you have to go to an oncologist or hematologist for it. It's like, was it once a year or once every 6 months? Yeah. It's a great therapy. It's a great therapy. Gastrointestinal issues. In the old days, we'd have something called bacterial translocation. And what happened is when you're living with inflammation, common theme here, I keep saying inflammation, the lining of your gastrointestinal tract would be inflamed, and in between each cell there'd be a space for bacteria to leak out of, and the bacteria would leak out of your gut, where normally it would be destroyed by the acids, go into free spaces in your body, and then cause infection. You'd have more inflammation trying to fight all these infections that leaked out of your gut. Nowadays, with the new HIV medications, we don't see as much translocation as we used to, but it still exists. One thing that you can do, especially as you get older, that you need to do, is you need to have a high fiber diet. I have fallen in love, and I'm not embarrassed to tell you, with Metamucil. I love Metamucil. I had some surgery a couple months ago, and my surgeon said that, I'm not going to be personal and tell you what the surgery was, but you could guess. My surgeon said, you need to take a lot of Metamucil right now. Your bowel, your stools need to be bulky and soft, whatever. And ever since I got the powder and I put it in the liquid and I drink it, it's like Tang. And I've used Metamucil ever since. It's just good for your GI health. I feel healthier being on Metamucil, and I really believe it's the Metamucil. And I'm sure one of the questions I should have asked in the poll is how much fiber you're eating every day. I can bet you 90% of you are not really having enough fiber in your diet. I really recommend, to prevent this bacterial translocation and to stay healthier, is to take Metamucil every day.
Is that once a day, doctor?
Twice. You start with once a day, and then after a week, go to twice a day.
A 6-ounce glass of it with water? Or how?
Yeah, about 8 ounces with a teaspoon. I don't like the capsules. I don't like the wafers, because in order for Metamucil to work, you got to have a lot of water. So I love the powder, and I recommend it for everybody. And it is sugar-free, yes. Probiotics are good as well, absolutely. So we talked about inflammation already, how it affects the cardiovascular system, your lipids, diabetes, lipodystrophy, and renal, your kidneys as well. The other thing I started getting into is turmeric. Turmeric is an Indian spice, and it's been known to be a great anti-inflammatory. So I get mine at Costco's. It comes in a liquid. I put like a tablespoon in a big glass of water and drink it. But there's turmeric capsules that you can buy at the pharmacy, or at like General Foods, a whole health food store. Turmeric is a great anti-inflammatory. The Indians have been using it for many, many, many years. And I talked to Devel, our pharmacist, to try and get it in our pharmacy as well. But you really should, if you're interested in inflammation and lowering it in your body, I would go on the supplement turmeric. It cannot hurt. People that have HIV are at increased risk for heart attacks. Here you can see the green line is the incidence of heart attacks in people living with HIV. Obviously, as you get older, it increases in risk, but it's always higher than the non-HIV infected individual. The risk of heart attacks is greater. What does that tell us? We got to be more vigilant, more preventive with you in avoiding all cardiovascular risks, from high blood pressure to cholesterol to diabetes. We can't allow little bits of any of that to exist. We need to treat it medically. Renal disease, this is really scary. The blue bar represents the incidence of renal disease in the general population. The orange above it represents the incidence of renal disease in those living with HIV. You can see, going back from the year 2001 until now, the incidence of renal disease has dropped significantly. That's because it's because of the medications we're using are less toxic to the kidneys compared to how they used to be. And I think since we made a couple other changes since this slide, the renal disease has actually fallen even more, because we've gotten rid of a lot of nephrotoxic drugs. I talked earlier about how liver disease used to be the #1 cause of death in those living with HIV. Now it's non-AIDS related malignancies. But if you look at the difference between liver disease on the left side of your screen and liver-related deaths on the right side of your screen, The blue is the prevalence of HIV positives. The orange is those living without HIV. Look at the difference in the incidence of liver disease between HIV and non-HIV populations.
I think you flipped blue as the HIV negative.
Thank you. That's my old age setting in. But you can see the difference is huge. And some of the things that you could do to help yourselves with this is to avoid extra drugs, avoid extra medications. We need to review your medicines and get rid of the non-essential ones because everything goes through your liver, your kidneys without exception. So we really need to avoid whatever extra drugs that you're on that you don't need to be on. And if you drink a lot of alcohol, I think you should cut down on alcohol. It's easy for me to stand from the pulpit here and give you all this great information, but we're all humans. I'm far from perfect, and I don't expect anybody in this room to be perfect either. But you know what? As long as you're educated and you do your best, you can do your best.
Make sure you're screened for and know your viral hepatitis status.
Absolutely. Hepatitis B, hepatitis C, even hepatitis A. Did you have a question back there?
I was going to ask you about the alcohol, and you just kind of answered it. To kind of do the best you can.
Alcohol is like putting gasoline on a fire if you've got liver disease.
So it's best if you can to just cut it out of your.
I would say cut it out or drink seldomly. So there's a lot of improvement opportunities. Get rid of bad habits, pick up exercise program, review your medications. Don't be on what you need to be on and not things extra. Good nutrition is important. Exercise. We talked about sleep hygiene, and we talked a little bit about supplements. And I mentioned turmeric is one good supplement that's anti-inflammatory. There's some debate about aspirin usage in people over the age of 50 for heart disease prevention. It's recommended for people that have heart disease. It's not recommended anymore for people that have normal cardiovascular status. But I would put up an argument and say that if you are living with HIV, that's a risk factor for heart disease in itself, and that everybody, unless there's a contraindication to it, should be on a low-dose aspirin every day because it has a great anti-inflammatory effect. But that really needs to be a one-on-one with your provider, rather than a blanket statement for everybody.
Esther had a question. Sir?
Yeah, 1 second. Yes, Esther. It really doesn't make any difference. It can be taken anytime, day or night. So we have the science to eradicate HIV. We have the science to keep people living long and healthy. What gets in the way here is politics. And it's not necessarily with this administration, it's with many other administrations moving forward. Politics really clouds the water. We don't have the social programs in place to make sure that no one is left behind, that everybody is being treated appropriately. We have U equals U, undetected equals untransmittable. That was brought out at the last World AIDS Conference. Very, very big. It's nice for me to tell a couple that's in a monogamous relationship that they do not need to use condoms anymore. That's true for everybody, but everything in life comes with a risk. Driving your car here to get here tonight was a risk. And for a lot of people that are not sure if their relationship is monogamous or not, U equals U may not necessarily be right for them. But for a number of my patients that I know that have been partners for 20, 30, 40 years and are in a monogamous relationship, it's so nice to be able to let them make the choice for themselves to not use condoms anymore. And then PrEP, using Truvada for HIV prevention. You should all be diplomats and couriers of the message to use PrEP. What really shocks me is the discordance of the PrEP uptake. In other words, most people that are taking PrEP are Caucasian men. most people that need it most, that have the highest incidence of new cases of HIV, are African American men. Yet this group is the ones least getting Truvada or requesting Truvada or being offered Truvada. So, you should all be the messengers of HIV prevention to people that you know that might be having high-risk behaviors or have a serodifferent partner to talk about that added layer of protection. So, living well after the age of 50 with HIV can be like a walk on the beach. You just need to take advantage of all the technology and all the medicine and experience that we've learned about this disease to take advantage of it. It's really not that difficult. It's not anything to fear. We all get older. That's a good thing. Nobody gets out of this alive. But you know what? Let's make our time here count and do the best that we can do to keep ourselves healthy. You need aggressive medical care and prevention. So I want to tell you what the Be Well Medical Center's plan is to help address this problem of being over 50 with HIV and living well and getting comprehensive care. It's something that's going to take providers a lot of time. And it's not anything that we can take one visit and get all these problems addressed in one visit. So one of the things we're doing is the group medical appointments that we talked about, where we're going to pick one subject, a group of 10 people, get in there and take a deep dive into osteoporosis or heart disease or whatever that topic is going to be. The other one is my secret weapon. And my secret weapon is sitting in the far back corner of this room. Colin, do you want to stand up for a moment? Some of you may know Colin. He is a man that has impressed me greatly. He's a physician assistant. He just graduated a couple days ago from school. Yes. We've grown very fond of him. We find him to be very intelligent, very personable. I sometimes call him Caleb Jr. He knows the bar he needs to reach up to. Good luck on that. But Colin is going to be, because he's not going to be that busy when he starts with us on June 1st, he is going to specialize on taking care of HIV individuals over the age of 50. Him and I are going to work together as a team. You can make your wellness visits, schedule it with Colin. I'll be around. I may or may not pop into the room, but we'll be going over everybody individually together on that. And he's going to have the time to go over and make a comprehensive medical action plan to address this midriff of all these concerns that we've got to deal with to optimize your health, okay? And of course, Caleb Boy Wonder, he's going to work with us as well on this. And we're going to work together as a team, which our clinic has really become great at, is working as a team with teammates. I think we finally got our act together, and hopefully it'll stay that way, that it's going to work well for you. But you know what? You guys need to be an active participant in your healthcare and be part of the team. You can't just come and expect us to do it by ourselves. I got a couple polling questions and then we're done. You've been a great group. So back to your cell phones. I found this program to be, and then you could type in any one or two words that you want to type in and then hit send. I found this program to be boring, educational, fabulous. I'm just giving you some ideas. Fantastic, okay. The larger the number is, the letter is, the more it is. So fantastic, great, informative, enlightening, awesome, beautiful. Thank you. You know, this feedback is important to me because it takes a lot of work to put a slide presentation together, and it's nice to know that it's appreciated. And we run around so much in the office that we really don't have time to just sit and talk. And I'll be available after the program as well to hang out if anybody wants to talk. Okay, great. So there was nothing negative in here. I thought somebody would throw something negative in here as a joke. Thanks, Dorothy. Beautiful. I think everybody responded. Well, that's all right. Fantastic is close enough. Thank you very much. All right, a real quick question. There is more I can do to keep myself healthier. A is true, B is false. I would have expected this answer. Great. And then the last question of the night is, I'm interested in group medical appointments. If you are interested in a group medical appointment, you need to reach out to Kiana Nance. You can call her or email her or use our portal system. She will get your name, schedule an appointment for you, and we'll get the first meetings going on that. I'm really, really excited about the GMAs.
I remember doing those years ago.
Yes, yes, beautiful. Thank you all for coming tonight. We started on time, we ended on time. Life is wonderful. Thank you. You're welcome.